Dr. R.C. Deepak, bilateral angle closure. So we have another one, angle closure. Great. So don't waste your time by saying so and so and so. Just go straight for the topic.
Good afternoon to you all. Case is rare case of bilateral spontaneous angle closure glaucoma. Case details: 42-year female lover presented with acute bilateral diminution of vision, pain, redness, and swelling in both eyes. Symptoms were accompanied by severe headache, progressive visual impairment, and elevated IOP. Patient had prior history of unilateral headache and was a known case of hypothyroidism. On 23/11/2024, she presented to us with right eye vision of 6/24 and left eye 6/12, with a pressure of 60 in right eye and left eye 31. Cornea right eye was hazy, left eye was clear. Pupil was normal. DT was stony hard in both eye and was managed with tab acetazolamide, TDS, dorsalamide 8-hourly, timolol BD. Next day, the vision of right eye was 6/12 and left eye was 6/36, and pressure was both eye was non-recordable. Both eye conjunctiva was congested and chemosed. Cornea was hazy, AC shallow, VH grade 0, cells occasional, pupil was mid-dilated and fixed, DT was stony hard, color vision was normal, and contrast was right eye 5% and left eye 25%. Hertz were 20 and 19 respectively. Injection mannitol 300 ml infusion in 1 hour was given. Eye drop brimonidine plus timolol, TDS, pilocarpine QID, CMC 1 hourly, prednisolone 8 times, syrup glycerol 380 ml, TDS was given. Next day, the vision got improved to 6/6 in both eye. NCT of right eye 15 and left eye 16. CCT was within normal limits. All other findings were within normal limits with AC depth of VH grade 1. Eye drop moxifloxacin plus lotipratinol 6 times, brimonidine timolol QID, refresh TS 6 times, tab Dimox was given. This was the picture of the presentation, and this was 2 days after. This was the slit-lamp examination showing VS grade 1 and fundus picture showing optic disc blurring and hyperemia of disc. This is the AIOS showing right eye showing angle 14 and 8 in right eye and AC depth of 1.10 millimeter. Left eye it was 12 in both sides and AC depth of 1.123. 2 days after AIOS angle got improved to 20/23 in right eye and AC depth of 1.5 millimeter. In left eye it was 22 and 19 with AC depth of 1.452 millimeter. What's unique? The case is unique due to the simultaneous bilateral presentation of angle closure glaucoma, which is relatively uncommon. Additionally, the presence of hypothyroidism raised the possibility of underlying systemic influences contributing to the patient's condition. Response to the treatment as followed, as documented in the follow-up visit, highlights the dynamic nature of glaucoma management and importance of personalized treatment strategies. The case underscores the need for comprehensive ocular and systemic evaluation in patients presenting with sudden visual disturbance and pain. Early recognition and aggressive medical therapy can prevent irreversible optic nerve damage. The association with hypothyroidism also calls for the interdisciplinary approach in managing such cases. Simultaneous bilateral angle closure glaucoma is rare but sight-threatening condition due to requiring immediate intervention. High index of suspicion, timely referral, and appropriate medical management are crucial. The case highlights the importance of recognizing systemic association and the role of thorough follow-up in ensuring optimum patient outcomes. Thank you.
So, good case, Dr. Deepak. Mics are not working. Can you hear me?
Yes.
Okay. So, first of all, I felt that your examination results were a little skewed. You'd made up your mind that this is the diagnosis, and then retrospectively, you're writing the examination details. So make it very, very fair. Just if you're presenting this case in front of an examiner, that really matters. So don't use strong words like stony hard, you know, one eye vision was gone next day, brilliant vision. So let's not do that. Give facts, okay, and then slowly, gradually come to a diagnosis, logically, step by step. Okay, so also what we did not understand, how ma'am was also pointing out, how color vision was taken. How was that possible with a hazy cornea, with a 636 vision, stony hard eye? Patients generally don't cooperate. Even if they do, you even said the fundus is hazy, so it's very difficult for color vision to come out as 21/21.
Fundus was not hazy. The optic disc was blurred, and there was slight hyperemia. Fundus was clear.
Right, but you think these?
I would agree with that it is, it's very difficult really for us to understand how a person with 60 pressures, you know, you'll be having so much of corneal edema that you are being able to see the fundus. Or for that matter, you are being able to even check the vision. Or for that matter, you're being able to do the color vision or the contrast. In fact, it would not have even occurred to me to do the color vision, to tell the truth. Yeah. No other
Yeah, I
question,
agree.
then it's okay.
It becomes difficult, practically speaking, with the steamy cornea at 60 millimeter of mercury pressure, where it is difficult to go see beyond the cornea. You cannot expect patient to be able to really see, do the color vision testing. I think it is unthinkable. Anyway, so this is just a advice what we are giving you. So color vision is not possible. You could have said color vision was tried, testing was tried, but it was results were equivocal or something like that. Okay.
So color vision was not done on the first day when the pressure is, it is done on the second day, when the pressure became normal.
In 1 day's time, the pressure reduced.
From 62, it came down to
60 to 15, but second day 50. First day
Within
it was
1 day.
60. No, first day it was 60.
60.
Ah.
Second day it was
Yes,
15.
No, not recordable. Then third day it was 15.
Was any laser done? Was a
No,
laser
sir.
PI done?
No.
So how do you expect an angle closure to settle without you opening up the angle just by medical management? What was the cause of angle closure? Was there a secondary cause and not a primary angle closure? Is
In
this-
MRI was done, ma'am, and it shows mild inflammation of the extraocular muscles.
Okay.
So how
How
will
is that
how
correlating
does
with
that, do you think,
intraocular findings?
how do you hypothesize that swelling of the extraocular muscle will lead to,
Swelling
it is
of
not
the,
that means it's non-pupillary block mechanism?
it may, the swelling of the extraocular muscles and preseptal tissue may lead to angle closure.
And also, why should you even think of an MRI in a case of bilateral angle closure? I'm sorry, I'm not being able to understand. Anyway, it's okay. It's okay.
Right.
See, I said, courage to come along and present. Great. Thank you. Thank you.